Welcome, everybody. Lots of people showed up today. This is fantastic. I'd like to welcome Arthur Bergeron again to the Salt Marsh with his guests, Dr. Tim Lepre.
And the distinguished Peter McKay from Nantucket Hospital.
Took the words right out of my mouth.
Thank you.
Thank you.
Thank you, Laura, for inviting me, and thank you very much, all of you, for coming to this installment of the presentations that I've been doing here, I think now for about 4 years. And as you know, so that's me. I'm Arthur Bergeron. I work at Myrick O'Connell. There are 68 of us at Myrick O'Connell, so everybody gets to do what they really like doing, and I like doing elder law, and so that's why I do this. And the purpose of these presentations usually is to talk about a particular issue about law, to talk about general elder law, blah, blah, blah. But this is a kind of a topic that's really much more important than law, I think. And it's really about, for want of a better term, honoring choices. It's really a statewide program which was initiated by a woman named Ellen D. Payola, a wonderful lawyer who's a nonprofit type person, who was really dedicated to trying to get everyone to make sure that A, they have a healthcare proxy, and that they've told the person they named that they're the proxy. You know, that's a good thing. And B, that they've talked to that person about how they want to be treated if they are in a position where they can't say how they want to be treated, which is the really important question, which really means, C, that the goal is to encourage you to think that out. Suppose that you're in a position where you can't say how you want to be treated. Now, in the worst case, that's because you're on the floor and the EMT just showed up, and the question is, do we want to revive you? But you know, it could also be a question that lasts for a year. You have a stroke, or you develop dementia, and you can't be making these decisions. But you'd like to think that there's somebody there who is doing the thing that you would really want, right? Even though you can't communicate it, or maybe don't kind of have the wherewithal at that point to communicate it. So this is what this is about. And by the way, there are also number of you have picked up handouts in addition to these slides. Talking about honoring choices. There's a copy there of also of the MOST form talking about life-sustaining treatment. We're going to talk about a lot of that stuff. So I'm going to start off by just talking about a few things on the just healthcare proxy and kind of what that story is. And then Dr. Lepre and Peter are all going to sit over there, and we're going to talk about the rest, what the decisions are that you're making when you're doing the decisions on the MOST form, what they mean, and how you might want to think about them. And then more broadly, in situations that aren't an emergency situation where an EMT needs to decide something, right? But they're situations where you're just trying to figure out how you want to be living the rest of your life, and at what point you feel that life is still worth living, right? How you kind of think about that and communicate that. So, broadly, that's what honoring choices is all about. We're all on a journey. The journey ends when we die. We all die. I occasionally get a client who tries to do a plan based on the theory that he's not going to die, and I keep saying, you may be the lucky one. Not for me to say, but chances are, right? And the nice thing about elder law, I always like dealing with seniors because we all get this. Your kids never do. They're like, oh, you're never going to, we don't want to talk about this stuff. You're never going to die. Give me a break, kid. I'm going to die. You get older. And your goal, when you get to our age, is not to not die, right? It's to live as well as you can until you die. And that's kind of like that's the question. And maybe it's not even to live like as long as possible, but to live as long as you're living a really good life. So the things you need to do, you need to find a healthcare, sign a proxy. And by the way, the person you name in your proxy isn't actually the proxy. Technically, he's called the agent, the healthcare agent. And then you want to write down how you'd want to be treated so that you're helping your proxy out. By the way, that document, often called a living will, is not legally enforceable in Massachusetts. So you should understand that when you're writing those instructions down, you're helping your proxy, your agent, figure out what to do on your behalf, right? But it's not legally enforceable. So you really got to trust that your agent, right, that he or she is really going to do this. And a lot of this is about talking to your provider. And that's one of the reasons I asked Dr. Lepre to come, as well as Peter, because I think they're facing these kinds of questions. Dr. Lepre was just saying he was facing it like today, right? These issues are like all the time. So, briefly, healthcare proxies. In order to be valid, a healthcare proxy has to be signed by 2 witnesses. No notarization required. Can be signed any place. The witnesses can't be the people that you're naming as the agent, right? They also can't be employees of a hospital or other medical facility in which you are, unless they are also blood relatives of yours. The healthcare proxy only kicks in once the doctor has in writing said that you're unable to make a medical decision. By the way, I'm just going to, in parentheses, oftentimes when that happens, hospitals and others say, oh, well, in that case, and by the way, now the healthcare proxy has been invoked, quote unquote. And so that person can't sign a will, can't sign a power of attorney. That's all false. That's all legally false. What a healthcare proxy, what the doctor's certification is that you don't have the capacity to make a medical decision. Those are complicated, right? So you can totally have the power to still name somebody as your attorney or to do various other things, but not be able to figure out what the hell Dr. Leprey's talking about, you know, because that stuff's really complicated, okay? The agent, and one of the things that's nice about the proxy, though, is that your agent, whether or not the proxy has been invoked, can always get your healthcare records. So if you're in the hospital, they can go talk to the doctor, get the records, try to help figure out and help you figure out kind of what your situation is. The limits on the proxy. The MOLST form. One of the other things we're going to talk about today, and I've mentioned before, the MOLST forms, M-O-L-S-T, Medical Orders for Life-Sustaining Treatment. Those are the documents that have displaced the so-called DNR, or Do Not Resuscitate documents. The Department of Public Health is encouraging people to sign them. Interestingly, they're only encouraging people to sign them if in the opinion of your doctor, you don't have that much longer to live, or you're like really frail, right? Not long, meaning like a year. But they're always valid if you sign them. You can sign them and be 16 years old, and the MOLST form is valid. In the MOLST form, you and your doctor are sitting together, and you're making a set of decisions regarding things that you don't want to have happen to you, right? These are all things that, in the absence of the MOLST form, would happen to you. You get resuscitated, you get intubated, you get driven to the hospital. There are a whole bunch of decisions that are automatic medical or the standard operating procedure, unless there's a MOLST form. So the question, one of the questions is, so is the healthcare proxy's power limited by the MOLST form? Well, interestingly, the person you name in your healthcare proxy always has a right to overrule your MOLST form. If it has been said by the doctor that you can't make a medical decision because your agent replaces you in terms of making decisions. I will give you, though, one interesting case, which is the one that often comes to mind. So you're on the floor, the EMT shows up, you've got the MOLST form in the right place, which is on the refrigerator. You always put it on the refrigerator. Why is that? Because that's how EMTs are trained, is that if you go to the house, someone's on the floor, you look at the refrigerator, right? Nothing on the refrigerator, we're going to start working because they're busy. You're on the floor. They don't have much time, right? So you got to put it on the refrigerator, okay? So they see the MOLST form in the refrigerator, and they open it, and it says, do not resuscitate. But your husband's right there, and your husband is named in your proxy, and he's got the proxy, and he says, oh, no, I want you to resuscitate my wife. What to do for the EMT? The EMT, and I just went to a presentation by the regional director of EMTs in our part of Massachusetts, who said what the EMT is instructed to do in that case is not resuscitate you. Not resuscitate you. And the theory being that the proxy only takes effect when the doctor has certified in writing that you're not capable of making a medical decision. And you may be on the floor, but at that point, the doctor has not certified in writing that you can't make a medical decision, and therefore the EMT is going to rely on the MOLST form, okay? Personal directives. I'm just going to mention, I was just talking about this. The other thing you need to do, you really need to do it, just so that you're not going to, so that your agent isn't going to be overwhelmed with guilt about this stuff, about how she or he is treating you, is write it down. Explain to that agent how you want to be treated or not treated, and think about that, and we're going to talk about that some more today. Remembering that that's not a legally binding document. Living wills in Massachusetts are not legally binding. Once you've signed your proxy form, You can still always refuse treatment. You can always refuse treatment, and you can always revoke your proxy. And for purposes of revoking your proxy and saying, I don't want you to do this anymore, even if the doctor says you're crazy, for purposes of revoking your proxy, you're presumed competent always to revoke your proxy. So, because the whole idea behind these was to keep you in as much control as possible. By the way, whenever you do a new proxy, you have automatically revoked all of the old proxies. And as I mentioned, you're presumed competent for purposes of doing this. So, the medical orders for life-sustaining treatment. What I wanted to do at this point is ask Peter McKay and Dr. Lepre to come up and sit here. And we're just going to talk about this form. Once again, this is a form that needs to be signed, have a mic, by both you and your doctor, or a healthcare professional, either a physician's assistant or a nurse practitioner can also sign them. And they're signing them verifying that you knew what you were doing when you signed the MOLS form. So you can't just sign the MOLS form kind of, in your house, because we want to make sure that that you knew what you were doing and you weren't getting pressured, okay? So one of the first question, there are 2 pages of the MOLS form. Or like a front and back, and one side is basically the side that the EMTs look at. It's regarding the decisions which are the kind of emergency decisions kind of on the spot. And the other side, for want of a better term, is what the doctors look at and the medical people when you get to the hospital. They're kind of more long-range things. So I just wanted to talk about these. So, do not resuscitate me. So, doctor, can you just talk a little bit about what does that mean? What does resuscitation mean, and why might you say, don't resuscitate me? Because they will, if the EMT shows up, they will resuscitate you unless this form exists.
Well, the resuscitation involves, depending on what the situation is, CPR with chest compressions. It can involve ventilation, breathing for you, either with a mask or occasionally intubating. These are the events that really start the whole thing off. If a patient is requiring CPR, this is a situation that is probably not going to end well, but this is the one chance for the individual to have a chance. This is serious. This is bedrock stuff. If the patient requires CPR and it's not done, the patient will expire. That is not always a bad thing. People have MOLS forms and do not want to be resuscitated. There are a lot of good reasons for that, but that's a very personal decision. And that's why the MOLS form is very, very important. This is, for want of a better term, a very aggressive, intrusive option for people, because it doesn't usually ends up with broken ribs, and occasionally is successful, but the patient should have that decision made ahead of time, because it is aggressive, it is intrusive, and a lot of people don't, particularly since I'm up in the age group, some of us don't want to be resuscitated.
So ask him if he's done a MOLS form yet.
I have a MOLS form.
Well, there we go. There we go. That's good.
I have a MOLS form, and I discussed it with my wife, and she wanted to activate it prematurely, but I think...
That's why you got to have the other doctor there, right? After a couple glasses of wine, those forms, the answers start changing.
This is an aggressive, intrusive procedure. Sometimes it's warranted, sometimes it isn't, but you should really make this decision ahead of time when you've got a clear head, and because at this point, when you're doing resuscitation, the patient is not able to respond and say, boy, I really don't want that.
Now, doctor, I had heard that for folks who are at advanced stage. I was talking to a doctor from our area. And by the way, interesting piece of trivia about Dr. Lepre is that he grew up in the town where I live, right? Yeah, before he decided to go upscale and move to Nantucket. Right?
I'm much older than he
grew up in Marlborough, Massachusetts, right? So I had heard from a gerontologist that practices around there that if you're over 70, the statistics she used was that if you're over 70 and you get artificial resuscitation, the likelihood of you being resuscitated is like 25%, and therefore living like getting resuscitated. But then your likelihood of living another 30 days is also only 25%. So your ultimate likelihood of survival is really low. From your experience and from the stuff that you've read, is that a what do you think?
Well, I mean, if you require CPR, the statistics are it's not going to work. And if it does work, the chances that you walk out of the hospital are a whole lot smaller. You know, you can resuscitate somebody, but they're severely impaired. And that type of life is not something I think most of us would really want to have. Being on a ventilator, getting artificial feedings, having a lot of procedures done by anxious medical students and residents. I mean, it's the chances of it being successful and you walking out neurologically intact are pretty low. The chances that you'll be resuscitated are low, but if you are, an awful lot of people are neurologically severely compromised. And that's what the facts are, and that's, again, I think all of us sitting in this room would say right now, boy, that sounds crappy, and it is. And it is, it's not a good ending, I don't think.
And by the way, I typically hold until the end for questions, but not this time. So for this presentation,
No.
we're going to take questions as we go along, and if we don't get to the end of the presentation, that's okay. Okay?
I don't even know in what condition, when they would do this, but do the EMTs do that electric?
And the question, we're just going to repeat the question so that the cable picks up. So the question is, well, and because I see it on TV, right? So don't the EMTs do this electroshock thing? Because I always thought that it's that, you know, but then I see the paddles and all this other stuff.
Well, initially, you do 30 compressions, 2 breaths, and you do that for a couple of cycles. Then you take a look and see if the patient has a rhythm. And then if a patient is starting to have a rhythm, then you can shock it. If the patient doesn't have a rhythm, they will do it another couple of times running through that cycle. But, you know, every minute that you're down and requiring resuscitation, you're losing brain cells.
So Peter, from your perspective, because you're seeing this stuff all the time, I guess, so do you require most forms from folks that get to the hospital, or do you, you know, what is your view? And once again, you've been around like almost as long as Dr. Lepre, for God's sake. You've been here for a long time. So
Still got hair though.
and you know, the great thing, the first time I met Peter, this was several years ago, and I said, "Oh, you should meet Peter. He's been really good, but he's about to retire." Now, I think that was about 4 years ago. And
I'm not very good at this retirement.
he's a great almost retired person. He's just a true. So Peter,
First, just a quick thought. My experience with the CPR component is that a lot of people choose to have CPR because it's the urgency of make or break. If you don't do CPR, like Dr. Lepre said, you're not going to make it, period, end of story. To give them the chance to think with a little bit more time about what they want to do, as opposed to, if I don't do that, I've made the decision. Some people certainly, and Dr. Lepre described it very well, say, I don't want to go through that with the limitations and the complications that invariably the odds are you're not going to be as healthy, even with a successful CPR resuscitation. So I've, in my experience, found a lot of people choose to have CPR, but if you ask them, do you want ventilation, artificial feeding, none of that. No, that's a long-term thing. So just identifying that point, and again, every person's decision is good for them. Okay, just because somebody makes a decision one way doesn't mean that somebody else should make the decision that same way. You're based on quality of life. And one of my acronyms for a long period of time is that there is one more constant between death and taxes, and that is quality of life. Every single patient I've ever dealt with in my 33 years my goal is to provide them with the best quality of life. Now, it may have been this broad 20 years ago, and it's this broad now, but it's still the same focus. So you have to ask yourself, is the quality of life after CPR worth it? And everybody's decision is the right decision, as long as you think about it. Not thinking about it is the wrong decision.
Everybody's decision is the right decision.
Right.
That's right. That's
There's
kind
no
of-
question about it.
That's
And-
the bottom line.
In terms of the most.
Yeah, go ahead.
Like you said before, we don't recommend the most for everybody. There really has to be, from a physician's perspective, the patient's imminent terminality, that they're not going to be around most likely for a while. That's when the most really digs down a little deeper and provides a little bit more specificity about what you want and what you don't want. You go back to the living will. A lot of people say, well, I don't want anything artificial. Sign it. Poor Dr. Leprey's going, what the hell does that mean?
What's it, right.
You got it. There's so many different ways with which somebody reaches a point. So the most form digs down into CPR, digs down even into, IV fluids. It digs down into dialysis. I mean, it really forces you to answer questions in a way that provides a hell of a lot more clarity to the physician. Now, let's face it, if you have Dr. Lepre as your physician, he knows you pretty well. But what if it's an ER doctor? What if it's an ER doctor here? What if it's an ER doctor someplace else? They don't know you from a hole in the wall. So the more specificity a MOLS form provides is great when it's necessary. We do encourage everybody to fill out a healthcare proxy, without a doubt.
Right,
That
without
just
a
makes
doubt.
sense. I filled one out when I was 50. So,
And by the way, there were several, actually in our hometown, in Marlborough Hospital, they're actually doing kind of an active outreach with the senior centers in the area to literally try to get 100% of all the folks who are over 80 to have a healthcare proxy on file in the hospital. Because those are the folks that are going to show up. I mean, you're not going to go to Marlborough Hospital from Boston, right?
Yeah.
But everybody's going to come from these 4 or 5 towns, So you had started talking about, well, kind of going beyond resuscitation, there's intubation. There are these other things that happen. Could the two of you just talk a little bit about, first of all, what in the world does that mean? What is intubation? When does that come up? And what are the reasons why, and kind of what's that experience? Obviously, you've described the fact that CPR can be pretty tough on you. What's that like, and what are the places where you might want to think, nah, maybe I don't want that, right? Versus, yeah, you do.
Well, when a patient, let's say, regained a pulse, then you have to help them breathe. And there are 2 ways. One is with a mask, but the most effective way to prevent regurgitation is to put a tube down into their trachea. In an emergency...
Into their trachea, not that I'm a dope, but the trachea, which is...
Trachea right here, going down into your lungs, where down here it splits. But that
I try to
supplies-
use these as educational things for me.
It supplies,
I admit.
it supplies air to your lungs so that you have circulating oxygen in your bloodstream. Again, it is an intrusive, as you would imagine. Any of you that got a piece of meat stuck in your throat, it's uncomfortable, and having a tube down your throat is very uncomfortable. At that point, we generally sedate people because it is so uncomfortable that people will be grabbing at the tube.
And are there, once again, are there situations where people have, when you're talking about people ahead of time saying, you probably really don't want to be going there,
Well,
or is that really the same set of players that you're
It's-
talking about resuscitation?
It's an aggressive, intrusive procedure. That is why patients that are being intubated are sedated. They're at least made unconscious for the event and then sedated so that they apparently, not having been intubated, apparently are tolerating it. But it is aggressive and intrusive. And then once you've intubated somebody, then the risk of infection go up, the risk of regurgitation while you put the tube down, damage to the lungs if somebody breathes too hard for you. I mean, it's an aggressive, intrusive procedure, and you really should think about it because we're all on a journey. We're all going to end up at the same place, maybe not at Prospect Hill, but we're going to end up someplace. And you've got to understand that most resuscitations, as we're talking about resuscitations really in the home, are not successful. Probably 10% 15% of people are successfully resuscitated when this happens in the hospital, where I've got everything all set up. If you've been at home on the floor for an hour, it's never going to turn out good.
Peter, comments? Peter?
Again, the conversation with the physician about your particular condition is essential, because I couldn't speak to the specifics, and I'm not going to delve into the medical field too far beyond my pay grade, but there are people who have at times, for other more medical comorbidities, have been intubated and then been extubated, okay, and go on. Other people, when they get intubated, that's probably going to be it.
Now, is this kind of really a distinction between folks kind of in general versus folks that may just have, for example, a lung problem, and therefore,
Right.
you know,
Right.
you get them breathing again, the rest of their system is working okay,
Right.
but it's just they got a lung problem.
Right. So in that capacity, if you have a healthcare agent making decisions for you, and you have a cardiac condition that warrants the physician needing to intubate you for a period of time for whatever particular reason that Tim could elaborate on a little bit more, you may, go ahead, do it, because I'm expecting to be extubated after that stabilizes and go on with my life. As opposed,
extubated.
Extubated means being unintubated. You take
So
the
they
tube
pull-
out.
So they pull the tube out. They
You
pull
pull
the
the
tube out.
tube out, right. As opposed to somebody with chronic respiratory disease, that if you get to the point where you're intubated, the likelihood is you're probably going to be staying intubated forever. And that may be, that's not a quality of life. That's not a quality of life that I want. So but that's, again, unique to each person. So you just don't frivolously say, you make decisions for me, without having some conversations with your physician about your condition, about the possibilities. Play some scenarios out so that you know. Because if you don't know and you can't communicate, we're forced to make the decisions for you. And I don't want anybody making decisions for me. I don't think you want me making decisions for you unless they're your decisions.
So Peter, once again, from your experience at the hospital, what % of the people coming to the hospital at this point don't have a proxy?
Oh, probably 70, 75%.
Do not have a proxy?
Do not have a proxy.
Unbelievable. I would have thought it'd be like 10.
Nope.
I could understand that they wouldn't have like talked to their proxy. I hear that all the time.
Yeah.
But I only hear it from proxies. So by definition, I'm hearing it from a limited group of people.
Yeah,
Most
again,
people don't have one.
If you were to target the audience to those 65 and over, it might be a number like 40 or 50% that don't.
That do not.
Right?
Still,
But when you
wow.
include, I mean, let's face it, my kids, they're not thinking about that, just like Arthur was saying before. Kids aren't thinking about that. They're thinking about a lot of other things. So, but I would encourage everybody to have one. You never know, sort of morbid, but when a Mack truck's got your name on it, and all of a sudden you're in an ER struggling, and the doctor's going, what do I do?
What do you do? Right.
So directions make a big difference, yes.
Put this off if you're going to talk about it later. But all this assumes that when you have an emergency, you go into your home hospital where these materials are on file. If I'm driving to Virginia to see my grandchildren and it happens on the Jersey Turnpike, or even in Virginia, none of that is true. Are there portable forms that you can keep in your office? Mine says, you know, my physician is so-and-so. You know, how do you deal with this in 21st century, 20th still to me, 21st century life where people aren't linked to the communities where they live?
By the way, I'm going to make a legal observation on that, which is that in general, states honor each other's proxies. Not true with the most forms, right? Not true with the most forms. So if you're concerned about these issues and you're visiting someplace, or if you know somebody that's coming to Nantucket, like for the summer, right? And they're older, they're concerned about this. Tell them if they should be doing a new one here, because the EMT here will not honor that most form from out of state, or isn't supposed to.
But they will honor the proxy. So
But
my
they'll honor
answer
the
to you is,
proxy.
bring your proxy with you. It's a paper form, bring it with you. We scan it into the electronic medical record, which is available in most Massachusetts hospitals, but not in New Jersey.
Okay, other questions?
Having your agent carry a paper copy of the proxy is at this point, the
Having you carry it, not your agent. Because
Yeah.
your proxy identifies for you as the potential patient who would make decisions for you.
And that's why pretty much a standard piece of that proxy form is there's going to be an acceptance page by the agent together with their emergency phone number.
Right.
So if they get the number, they're going to be able to call or email, do something.
Exactly, right.
All right?
Thank you.
Other questions on this issue? Yes,
I
ma'am.
just want to know what the CPAP is, if you have that.
CPAP.
Okay, what?
A
That's all I know. It means CPAP. Yes?
You were intubated with an endotracheal tube down. And what we do is on the machine that's ventilating you, we sort of put a block on it so that you inhale completely, but you exhale against resistance. What that does is it expands your lungs. It expands the little sacs called alveoli and eases the transmission of oxygen back and forth.
Oh,
The CPAP, if you're awake, the CPAP is very uncomfortable. Usually, if you're intubated, you're sedated, and we can dial that up. Now, at a certain point in time, if we have more and more difficulty ventilating you, when we turn up the CPAP, then you can damage the lungs, and the lungs collapse. And
So that's
More than you want.
different, because I'm a CPAP user. So that's, you're referring to something different
Yeah.
than regular, I have sleep apnea. So I use a CPAP,
this is continuous positive airway
which is,
pressure.
just make sure there's a difference between, well, I'm a CPAP user, what does that mean? There's a difference there.
Thank you.
Well, it's just so you don't snore.
that's right. That was his wife's purchase. It's a Christmas present to
No,
herself.
that's what we use to open up the lungs and to give a maximum opportunity for transmission of oxygen across the alveoli and carbon dioxide coming back. It just expands them.
So now I'm going to get to my favorite. Do not bring me to the hospital. So if you've been here, you've seen my presentations and with my couple, Frank and Mary, and their kids, Peter, Paul, and Mary Jr., right? And I always make the joke, if you get that joke, you're old enough to be my client. So, but the point is, with their goal, as you've seen, is I always say, is they want to die and be buried in the backyard, right? They're living in their house. They don't want to, and that's a very good point. If you want to die and be buried in the backyard, I don't think you want to go to the hospital, because when you get to the hospital, and you tell me, but let me put it, I always tell this story. I used to be on the board of trustees at Marlborough Hospital, at our local hospital, and monthly, we would have trustees meetings, and it would include the scores for the month, how we're doing for the month. And among others, the scores was how many people died in our hospital that month, right? Oh, you didn't want that to be a high score, right? Because if that's a high score, then the Department of Public Health is calling, and people from Washington are calling, and so you don't want anybody to die in your hospital, right? So if you show up at our hospital, we're going to save you, right? Now, we're very concerned about your quality of life, but we really want to make sure you don't die in our hospital, that we can get you out the door, right? So that's my observation. Comments on bringing people, or do you have many people that on their molds they'll actually say, don't bring me to the hospital?
I've had a number of people.
Oh, you use the mic.
I've had a number of patients that want to die at home, and I think that's, to me, is the best way to go. I think when you enter into the hospital system, people like to do things. They do. I mean,
That's why they became
people,
medical people.
The only people that really don't are the oncologists and the pathologists. If you come to a hospital emergency room, hospital emergency rooms are set up to do something.
Make you live. To make you live.
Make you live. And now, if you have a form that severely limits the things we can do, then that's good. But I think I am very happy to see patients die at home. I'm happy to work with people that want to die at home and die in their own bed, surrounded by their friends, and not a group of nurses and docs that they've never met and could care less about. So I think when you go to a hospital, you're sort of flipping that switch. You're giving everybody a temptation, okay? And a temptation is a bad thing because people go into medicine, emergency medicine, to do things. They are not,
To save you. I mean, it's well-intentioned.
well,
right?
they're
You
not
wanna
great
save-
thinkers. They do not cogitate. They do things, okay? They're reflexive, okay? If you got this, we do that. They don't say, well, boy, I wonder if I should be doing this. They do it.
By the way, I'm just, oh, no, Peter, comment and then the question there, and then I have a comment.
Sure,
Yeah.
just going to give you the generalities of seeing so many of these over so many years, is that if somebody's pretty much, their quality of life is pretty diminished, they're going to go right across the board. Don't intubate, don't ventilate, no feeding tube, no CPR, no transfer. If somebody is picking and choosing, they'll usually say transfer. Because obviously, if you're picking and choosing, you're holding on to some measurable quality of life that you want to try, and you want that doc in the ER to try.
Because
But-
presumably, if you're going to the hospital, that means that you're still breathing and you're still, right?
Correct, as
Did you-
opposed to somebody who says, I'm at the door anyway. It's not quality, if I can't be home, it's not worth it. So those are the folks that usually indicate do not transfer, because they're checking no to everything else too.
Great, yes, sir.
I promise this is the last question, but I came here to ask this.
No, you're a local, you can ask whatever question.
Right.
I'll repeat the
My
question.
son's father-in-law lives on the beach at Nag's Head, think Cisco. He was surfing on Labor Day 3 years ago, and he broke his neck. He woke up being carried to the helicopter by the EMTs and was taken to a trauma center in Norfolk, Virginia. He didn't call the EMTs, somebody else very kindly did. He's paralyzed from his neck down. He can talk, he can feed him, he can swallow. He's lucky, and he can breathe without being on a ventilator. But the family is bankrupt, et cetera, et cetera, et cetera. How do you stop this process? Is there any way, if you're on the Jersey Turnpike or on the beach at Cisco, to stop the EMTs from doing what EMTs do?
In that situation, and I've done it, people can be intubated, they can be ventilated, they can get their neck operated on, and then they can be quadriplegic and wonder what the hell their life has become. I think always the question mark is, I can tell you on day 3, probably, say, you know what, you got a high cervical spine fracture, your spinal cord is severely damaged, you ain't getting better. The trouble is, it is very difficult to say that in the first 15 minutes. And so people tend to go all the way in these traumatic injuries. There are some people that they may just be paraplegic, and that perhaps is a little more acceptable. But one of my first summers out here, I had a principal with a C2 fracture. As long as we were ventilating the guy, he could mouth things and open and close his eyes, but that was what the life he was looking forward to. And that, unfortunately, is, it's very difficult to make that decision that early on. It becomes very clear, but at that point, the patient's sort of locked in.
So, Peter.
In terms of preventing that, very little chance unless the person had a healthcare proxy and an agent. Because those types of situations, the medical team is going to treat. That's the first thing. They have to be told otherwise. And even then, even if you got a healthcare agent, what you're describing as a younger individual, you're still going to find, practically speaking, resistance from the medical department. Because they're still going to, you can't get past the human element of looking at a younger person, regardless of the injury, and listening to somebody else, a mother, a girlfriend, a wife, of somebody saying, no, he doesn't want to hear that. Even with that's a difficult thing as it plays out in the real world sometimes.
So tattooing it on your chest, I mean, it really doesn't do any good, is what you're saying. No.
Probably not going to help you. So I want to, I was then going to talk about the second page, so the other things. So I'd like to talk about these briefly, but then I want to talk about this whole personal directive question of what you might want to be putting in a personal directive. So among the choices that you get, we already talked about this to some extent, is on the second page, they say, well, if you were intubated or ventilated, then the question is, do you want that to continue when you're in the hospital? So from your experience, do you have people that what do they say here?
It's usually either or.
It's either you're going to be intubated you're either going to be, you're in or you're out.
Yards or don't.
You're in or you're out. Doctor?
Well, I've seen it stopped.
You have seen it
I
stop.
have seen it stopped.
Now, once again, I had heard it said by medical professionals, boy, once you get them intubated, it's really tough to
Well,
get anybody to pull that tube out.
Not if you have the information that the patient really didn't want to be intubated. I think it is important to respect the patient's wishes and the patient's dignity. I think you stick a tube in somebody, you're not welding it in there. The tube can come out if that's not the patient's wishes. And I have seen that done. I think, like I said, you go to an emergency room, guys like to do things. Sometimes you got to put a stop on them. Sometimes you got to say, look, that patient did not want that. Get that tube out. The patient understood the consequences of taking it out, and then you go on from there.
And by the way, in that case, the moles had a significance to it, but at that case, you're in the hospital, so presumably, if you have a proxy, your proxy can stick up for you at that point. That's one of those things that you can help your proxy, your agent with, is that making it clear to them that no matter what the doctor says, you don't want this stuff, because your agent has the right to order that this stuff be pulled out, right, on your behalf. As soon as your doctor has said that you can't make the decision on your own, right? So it's one of those really important decisions. Can you just talk about this just briefly, the dialysis questions and the artificial nutrition questions? So that, once again, these are some of the options on page 2 of the MOLS form, is whether or not you want dialysis, whether or not you want artificial nutrition.
If your kidneys are severely damaged, probably during the resuscitation, but severely damaged, if you don't get dialysis, you will die. Dialysis is another aggressive, intrusive proposition. What generally starts out is a catheter is put in your subclavian vein, and then you're hooked up to a dialysis machine for 3 hours a day, 3 days a week. At the same time, another aggressive, intrusive procedure, somebody will start thinking about putting a fistula on your arm so that they can take this thing out of your subclavian vein and use the fistula. Dialysis is an aggressive, intrusive procedure. Now, dialysis may only be temporary, but it can also be for a forever procedure. But it's an aggressive, intrusive procedure.
Now, I had always thought of dialysis as being kind of by definition of permanent. So there are cases where the things get better and you can actually get off.
Well, it can get better, and then you don't need dialysis. It isn't always forever. A lot of times it is. But it starts off with a catheter in your subclavian vein.
Peter, comments?
We've had a couple people on Nantucket, probably almost everybody here knows them, who've been to dialysis, get a transplant. They're like everybody in the room right now. They're not going to dialysis anymore. So having worked in the dialysis unit here for a long time, you can maintain a semblance of a normal life with dialysis. It's a long-term thing in most cases, and it is intrusive, as Dr. Lepre said, but you spend 3 hours in a chair getting clean, get your blood cleaned out, and then the other 4 days of the week, you're walking around like anybody else. So that's a unique one as opposed to being on a ventilator where you're lying in bed and the machine's breathing for you. You're not, back to that quality of life thing. You don't have much of a quality of life if you're on a bed breathing through a machine. With dialysis, from my opinion, you can have a measurable quality of life. You can live a reasonably, with the hope that you might get a transplant, in which case even live a better quality of life. So that requires, again, that you heard from my tone, I'd probably go for that. But that's me. Everybody else has to weigh it out in their own context.
I would disagree a little bit with Peter. I think most of the, I know the people
But
that
you'd
are,
be wrong, says Peter. That
The
was a kind
people
of-
that are getting
I just wanted that on the
dialyzed-
camera. You know, I wanted to get that.
the people that are getting dialyzed on the island, it has been a gradual process to their renal failure. If you are dialyzed in this event, you've been resuscitated at home, you're ventilated, and you're dialyzed, again, your chances of walking out of that hospital neurologically intact are quite small. And if you add dialysis into it, this is really something that I don't see as particularly practical in the patient that's been resuscitated.
Now, yes, ma'am, and I'm going to take that question, then I just want to get to the personal, the
Just a quick
personal
question,
director.
both in the artificial nutrition and the dialysis, it says, use dialysis, but a short term only. What do you think would be a recommended short term? If after 3 weeks it's no good, you stop? What's the idea of short term?
So the question is, one of the boxes you can check on dialysis is, and it's this,
Short
there,
term only.
short term only. What does that mean?
What's a reasonable term?
Well, you can use the catheter that goes in your subclavian vein that's stuck in there. You can use that for a couple months. But again, I think it depends on the context we're talking about. If you are being resuscitated and you need dialysis, the smart money is not on you, quite frankly. And you can put down short-term, you can put none. I don't think it's going to make a particular difference because I don't think people that are getting dialyzed have had a gradual fall off in their renal function. If you require resuscitation in this type of situation, I think the dialysis is a moot point, honestly.
So this kind of gets to the question of you're developing this personal directive. Because, as you can tell from what the essence of everybody's conversation is, not only are you unique, but your day-to-day life is unique and changing. And so the real challenge for you is to have sat back and thought about kind of what your goal is here in terms of your life, in terms of what a quality of life is. I was talking with somebody earlier today, and I said, people have talked to me about what is the, for me, many people will say a quality of life. I don't want to live if I can't have conversations with other people, if I don't recognize them. In other words, if I've got mid-stage dementia and I just can't be communicating with other people. And I've said to people, I said, well, for me, that'd be all right. I could be okay just being, I like meditating. I like being in the moment. And that's really in many ways what mid-stage dementia is. It's really being in the moment, no past and no future. But the thing for me is that I don't want to be in pain. I just don't, if I were told, you got a choice. You can have a week and you're going to be in pain and then you're going to die, or you can have a year in pain and you're going to die. Well, I know where I'm going there in answering that question, So each person is really different that way. So I wanted to talk about that a little bit because many of these questions, I think, come out of, now I'm going to do an ad. Who has read Being Mortal? Oh, look at that. A lot of people. So for the rest of you who haven't, this is an ad. There's a book called Being Mortal by Atul Gawande, Gawande. First name is Atul. Written by a doctor whose father was a doctor who had immigrated from India. So this kid grew up in Ohio, now practices medicine in Boston and teaches in one of the Boston teaching hospitals and teaches at Harvard. But he wrote this book, I think, motivated certainly by his own patients, but also by watching his father go through what ended up being his death, over a long period of time. And the book is designed really to speak to folks in the medical profession in many ways. He says, he really wants doctors to stop, when you're dealing especially with seniors or people who are frail, stop thinking that their only job is to save them all the time, right? As opposed to their job being to kind of work with their patient to figure out what their patient wants for the rest of their lives and help them figure out how they want to live that, so that you don't define in a cancer case, success is we extended the guy's life for 4 months. My wife's sister died 3 years ago. She had cancer, and after 2 years of chemo, she was cancer-free, but she died because the chemo killed her. And in the meantime, she had 2 terrible years of going through nausea and all of this other stuff. So if you get a chance, read the book. It's really a fascinating thing. So in the personal directive section, what you're urged to do is to think about some of these issues. So these are the questions. So the first section is, so what are my personal preferences? What are your values and beliefs? As far as you're concerned, if you get unplugged, is it a sin? Are you going to go to hell after that? Well, that's really bad. In that case, you don't want to get unplugged, But what is your definition of quality of life? Which means, what really makes life worth living? What really makes life worth living? And what is your version of a peaceful death? Can I just ask Dr. and Peter to kind of comment on that? And then I have one comment on that.
I think the one thing that a physician should be able to do is to keep you comfortable. Now, what's comfortable? Comfortable may eventuate in you dying because you're being medicated for pain to a certain point. the facts, whatever you put down on the most form, you should be taken care of and kept comfortable. That's the key thing. That's the only thing we can do, really. Physicians are in a losing game, okay? All of our patients are going to die, but it's not a loss if we handle it right. If the patient is comfortable and if the patient is peaceful and we take care of the patients and keep them from being in pain. That's the one thing a physician could do. It's the one thing a physician should do.
From that perspective, you're really in a winning game. I mean, God made the game a losing game in that we all die, right? But you can really help people live as well as possible.
Well,
You
I
can't
think
make them not die, but you can make them
a
live as well as.
success is a patient that has a peaceful death, hopefully in their bed, with their pets
Right.
and their spouse.
Peter?
I can give you two quick examples to sort of emphasize the point. One is my own mother, who many of you knew passed away just last fall, but in her situation, her quality of life included, she had no physical abilities, but include eating, include talking. That's for sure.
Unlike her son.
Unlike her son. So, in any case, she could understand me as fast as I talk, too. So when she had a stroke, she couldn't eat, she couldn't swallow. But she was lucid, and she made the decision that she didn't want a feeding tube. This is just keep comfortable. So she had 2 weeks of meeting with family, kids, grandkids, sisters, family, and she eventually passed in a peaceful way. That's a good death that she controlled. Her quality of life did not include artificial nutrition, can't taste it anyway, and she enjoyed ice cream. She wasn't going to have ice cream anymore. So for her quality of life, that was the measure, which leads me to another gentleman years ago who was so respiratorily compromised that I had a long conversation about quality of life and what made life worth living. He was stuck in bed because he moving a little bit, and he would, what's known as desat, his oxygen level would really plummet to the point that he really couldn't breathe. He's on a lot of oxygen. So we talked, because he was alert and oriented as much as anybody in this room, but what would make life worth living? So in that case, he said, if I can get out of bed and walk a few steps and maybe get in a wheelchair so I can, because he was a social guy. And with the administration, as Dr. Lepre saying, of medication, in this case, a narcotic known as fentanyl, a patch, low dose, it decreased his respirations and he could do it. Just something as simple as getting out and walking a few paces so that he could get in a wheelchair and be social. That met his quality of life. Before that, he said, let me go.
Let me go.
I don't want to be here anymore. So sometimes...
What a gift. So what a gift he gave.
Yeah, no kidding. I get chills thinking about it because it provided a gift with a little bit more in-depth conversation, not quick, abrupt decision-making. Not my decision. All I did was talk with him about what would make life worth living. And surprisingly enough, it wasn't that much. And we were able to do it with the physician's help. So the only other emphasis I make is one of the points that Arthur went through quickly is that like you're competent until proven otherwise, you're innocent until proven guilty. That I would underscore that. You make the decisions until and if the doctor says you lack capacity. And even 5 minutes later, if you gain capacity again, they stop talking to the agent, they go back to you
go
again.
back to you.
It really does emphasize you make the call.
But that said, if there are particular things about how you want to be treated if you're really frail, whether or not you're going to be dying soon, to the extent that you've expressed that to your agent through your proxy, and ideally in writing, so that A, they're not going to have to try to remember. I was just talking to somebody, we were doing one of these presentations, a wonderful geriatric care manager, who said she was just dealing with her father-in-law, who was supposed to pass 2 weeks ago, and they did all of the things, and he's all ready, and and then he's still living, so no, they don't know what to do. But he had a really severe situation. They had to run him to the hospital, and so they thought he was really going to pass first. And she said she remembered, like the previous Thanksgiving, that they were talking, and they were around the table and stuff, and he was talking about kind of like what he wanted if something happened. And she said, I couldn't believe it. I didn't write it down, So I'm like trying to remember what he said last Thanksgiving, So do your kids a favor, write it down. I just want to do one, and I'm going to do one peaceful death thing. So I'm old, right? I've been practicing like forever. And I had a partner who hired me, who was 10 years older than me. He died 2 years ago. He found out year and a half before that. David Gabwood, local lawyer, pillar of the community, active, wonderful, still active in the law practice. But then he had some pain in his stomach. He goes to the doctor, and they open him up, and they said, oh, well, so the good news is that the cancer is slow growing, so you still got some time. But the bad news is the cancer was slow growing, so we never picked it up, and so you're definitely dead. I mean, you're going, right? There's nothing we can do. And so my partner's reaction to that was, he was just great. He says he went home, he talked to his wife, put up a sign in his bedroom, no tears. We're going to have no tears, right? He said, as far as his chemo, he said, I only want the level of chemo that will slow the cancer without making me nauseous, because I don't want to be nauseous for a single day, right? I want to enjoy every day. And he did, and he ended up, he was supposed to live 3 to 6 months. He ended up living 18 months. But there were many wonderful stories. We all have wonderful stories about people like this. But I'm going to do one. So he loved fishing. The guy loved fishing. He loved not just fishing, he loved packing one of those little inflatable boats and going into the woods to the pond where nobody was and making the little inflation thing go and jumping in the boat and fishing. So Thursday before the Monday that he died, he's in one of these boats, right? He was up in New Hampshire, and walked in, and he was in a boat. And he's fishing, and it's the afternoon. And I know the story because at his memorial service, I spoke, and a couple of us spoke, but one good friend of his spoke, who called him, and he's in a boat, right? And he's fishing, right? And then David says to him, he says, oh, wait a minute, I got a call coming in. It's from my doctor. Takes the call. Goes back to the friend. What did he say? Doctor said, oh, this is bad news. Said, we got the last MRI, and doctor says, got to get home right away. He said, well, what'd you tell him? He said, I'll be home tomorrow. So now, so I keep thinking of my partner. And it's late in the afternoon, and he's fishing, and he's watching the last sunset, his last sunset. And I think about there's a meditation site with a brother that says, live every day as if it's the first day of your life or the last day of your life, right? And so think of what that sunset was, the last sunset. And think to yourself, what do you want? What do you want for the last day of your life? And if you're not able to tell somebody at that time, isn't that a bummer that you didn't tell somebody ahead of time so they couldn't say, I really want to go, I want to see the sunset at Mattakit one more time, I want to see the stupid boat come in the harbor, You can give that to yourself. You can give that to yourself. So that's my little story. Doctor.
It's hard to beat that one.
But can't you? I keep seeing that sun. And he never caught anything. Of course, these guys, they just fish, right? They throw everything back. They go for the sunset.
All of the things that we said today, the important thing is your physician should keep you comfortable. Make your decision. It can be changed, but make a decision. And if your physician isn't keeping you comfortable, raise hell.
Get a new physician.
Get a new physician.
Right.
I'm assuming you can be kept comfortable at home.
And the question is, I'm assuming you can
You
become
can be.
comfortable at home.
You can be. I mean, we know about the opioid problem, but you know what? They work very, very well when used judiciously and for the right thing, and then keep people very comfortable. I mean, you should not be uncomfortable. There are any number of ways to work on keeping you comfortable. And it depends what the problem is. It can be addressed. And it's just, if it's not being done, squawk. Squawk.
Other questions? Other questions? Comments? I just want to briefly do a couple of these. So once you've figured out what you really want, you want to figure out also who should be getting notified. If you've got a personal directive, and do you want to share that with your kids? Do you want to have clergy involved at the end? Once again, for your kid, the view of clergy, in many ways has changed between you and your kids, right? They may say clergy, right? You may be really interested in having clergy there, right? So who is going to be involved in that stuff, and who's supposed to be doing what? We talked about that. What are your religious, what are the other kinds of considerations that, you want to deal with? And finally, in your final days, what does a peaceful death mean to you? And how do you want your remains to be treated, right? At the moment of your death, you stop being you and you start being remains. And you have how your remains get treated is totally under your control. You can just write it down, doesn't have to be part of your will, right? But if there are real concerns that you have of the way you want all of that to happen, once again, you need to get that written down someplace so that there aren't any questions. Any final questions? Yes, ma'am. Or Dr. Lepres.
Where do you get the most form? You go online?
The question is, where do you get the most from? On the Department of Public Health website, they have it, right?
They have them at the hospital.
And your doctors have it? They have it at the
Shocking
hospital?
pink.
Right? And once again, once you do them, and you can always rip them up, you can always change it, right? But make sure you put it on, it's no good if it's not on the refrigerator, right? Yes, ma'am.
One more question. Distributing ashes, can you distribute your ashes anywhere?
So, can you distribute your ashes anywhere? Yes, except within 1 mile of the coastline, because there is a Coast Guard regulation that says if you intend to distribute ashes, and if you're dumb enough to tell them that, they will require that you fill in a form and that you agree that you go more than 1 mile from the coastline. Is that a fair summary of it?
Yes, and also, when you're disposing of the ashes, make sure you know which way the wind's blowing.
Which way the wind's, that's right, we all saw those movies, right? Yes, I guess I'll take a couple more, I'm on the 440 boat, so I gotta be careful
Tim
here.
took my story, because I was out at Cisco one day when a former student was being cremated and.
Come on, they did
They
it?
went down to the water, they put the ashes in the water, but it never reached the water. The Coast Guard must have been looking.
Oh, the Coast Guard came.
And blew it back a mile.
Oh my God, that's a great story.
Never made the water.
That's a great story. Thank you very much all for coming, and thank you, can I have a round of applause for my wonderful guests? And we'll see you next year. Thank you. Thank you.